Well, good afternoon. This is Sara Selig. I want to welcome you all to the first Melanoma Research Foundation Cure Ocular Melanoma webinar. Today's webinar is about primary tumor genetics, prognostication, and implications for adjuvant therapies in ocular melanoma. We are very pleased to have two wonderful speakers today. Unfortunately, Dr. Carol Shields, who was supposed to join us today, sadly has a funeral she has to attend at the last minute. So we send our condolences to her and are thinking about her, and are very lucky to have Susan Walther, a genetics counselor at University of Pennsylvania, who specializes in ocular tumors and works very closely with Carol Shields and Takami Sato and their teams in Philadelphia on the call today. And she will be giving us a brief overview of genetics of ocular melanoma in Dr. Shields' absence. And we will coordinate with Dr. Shields to make up time with her at a future date. We also have Dr. Rich Carvajal on the line today, who's a medical oncologist at Memorial Sloan-Kettering Cancer Center, who specializes in melanoma. So we're very fortunate to have these two on our first webinar. This first webinar is the first in a series. We'll have 3 or 4 of these educational webinars a year that will augment our in-person meetings, like the one we just had at Thomas Jefferson University in June. So thank you all very much for being a part of today's webinar, and without any further ado, let me hand this over to Susan. Thank you very much.
Thank you. Welcome, everyone. I'm going to begin the first talk giving you an overview of genetics and the molecular testing. So talking about the 2 types of tests that are currently available. Next slide. So let's start first of defining what's diagnostic versus prognostic. The tests that we're going to talk about are prognostic, and I want to make sure that we have a clear understanding of the 2 definitions. I'm not able to move the slides ahead. Oh, sorry. So diagnostic. Basically, diagnostic is going to determine a specific disease. So the specificity of diagnostic is going to be different than prognostic. In genetic testing, a diagnostic test will confirm a mutation in a known disease-associated gene. So we have a disease, something like cystic fibrosis, hemophilia, sickle cell anemia. We know the gene that causes that disease, and we can look for mutations in the DNA of that gene. In pathology, an example of diagnostic is when the analysis confirms the cell type, the shape, the location. So it gives a specific type of diagnosis, a glioma, for example, in brain cancer, or ocular melanoma in the ocular realm. It also defines staging. So is the tumor benign or is it malignant? It also, if we look at a patient who develops metastasis, or what we think is metastasis, do we define that it came from the primary tumor or is it a new primary? And that can be determined, and that can be important for treatment. Next. For prognostic, we're going to determine the probability of developing a disease. So it's basically looking at a correlation. What's the chance that something that breast cancer or Alzheimer's is going to occur? In the case of the ocular melanomas, we're determining what's the chance of developing advanced disease, i.e. metastasis. So in genetic testing, the analysis confirms alterations that are correlated with disease. And then if you go back to the pathology example, the analysis will look at expressions of proteins that can guide effective treatment. So the example here would be the HER2 gene expression in breast cancer that can indicate that a particular treatment will, the tumor will respond. Next slide. So if we think of the central dogma of genetics, this is going to give you just a basics of genetics. We start with DNA in the cell. We go through what's called transcription to get to RNA. And then the RNA basically takes the DNA sequence and kind of shortens it and makes it into the coding areas that will then be translated into a protein. So what's functional in our bodies is the protein, and that needs to be folded correctly in order for it to be fully functional. So if we think about cancer, there are global changes in the chromosome pattern, and analysis can be performed on this global level. Next slide, or next. And this is an example of the chromosome analysis testing. So this is where we look for areas of genetic material that are different from the normal pattern. As we fine-tune or narrow down, we can then identify a pattern of expressed genes. Next slide. And this is an example of the gene expression profile, and this is showing where there's alterations in the expression of genes from the normal pattern, and this is often due to actual mutations at the DNA level. So chromosome analysis is looking for differences in large areas of genetic material, whereas gene expression is looking at whether a specific gene is expressed in a cell that you're analyzing. Next slide. In ocular melanoma, there has been an evolution of understanding the risk factors that indicate a more aggressive tumor from a less aggressive tumor. So if you think of a timeline, we used to classify tumors on their biology based on clinical factors, the tumor size, the location, the age of the patient, and what else was involved in terms of the diagnosis, so ciliary body, extrascleral, so how far had the tumor invaded in the eye. And then we understood that by actually looking at the pathology of those cells, we could classify cells in terms of shape. Were they epithelioid or spindle? So epithelioid is more cuboidal or squarish. Spindle is long and thin. And that was also an indicator of how aggressive the biology is. Next slide. Then we found out by looking at chromosome differences that we saw a pattern where in chromosome 3, and I will show you specifically what this means, that we saw a difference between disomy. So did the tumor maintain both copies of chromosome 3, or did it lose one copy of chromosome 3, known as monosomy? And so we added that to our ability to predict the risk for metastasis. Next. And then finally, where we are today, we have two tests. One is the gene expression profile test that most of you have heard about in terms of classifying the tumor as class 1A, class 1B, and class 2. Class 1 being a less aggressive biology and class 2 being a more aggressive biology. The second type of test is looking at the chromosomal factors, so looking at that pattern of genetic material loss or gain on chromosomes 3, 6, and 8. Next slide, please. So what are the testing options? Let's compare these two types of tests, chromosomal factors and gene expression profile. Next. The chromosomal factors is DNA-based assay, and it is done at the University of Pennsylvania. Next. It basically is an analysis to determine monosomy of chromosome 3 or amplification, duplication, it would be another word for amplification, of chromosome 8, so extra genetic material. And we're looking at the tumor cells as compared to a normal cell. And in our assay, the normal cells are come from a blood sample. Next. Basically, we're looking at DNA, so kind of a gene copy number, but on a more global aspect of groups of genetic material, so groups of genes. DNA is constant in our body, so once there's that change occurs, it kind of doesn't reverse itself. And the assay is determining the copies of genetic material on chromosomes 3, 6, and 8. Next. And the important part is obviously that the result is very reproducible. We want to be able to offer a test that we see consistent results from patient to patient or assay to assay. Next. If we look at gene expression, it is an RNA-based assay. So it starts with isolating RNA and actually does work itself backwards to a little bit of DNA analysis, but it's looking specifically at genes. Next. So it's an analysis of a profile of genes that have different levels of expression in the tumor cells. We don't need to compare to a normal like we do for the chromosomal factors. We can look just at the expression of those genes in that tumor. Next. And the result reflects a snapshot of how the tumor cells are functioning. So that's how we get our answer. What expression of genes are there, and that tells us how aggressive the biology of the cell is. Next. Again, the result is very reproducible. So when we look at these two tests, what's important to remember about these two tests? Next. Both tests will determine a risk assessment for developing metastatic disease. Next. The risk for metastasis is independent of the treatment type for the ocular tumor. So once we have a sample that provides either the DNA or RNA, we should be able to get a result that is reflective of the tumor before treatment. Next. And then for ocular melanoma, the chromosomal factors, the test for chromosomal factors does correlate with the gene expression profile. Both tests will classify the tumor biology as low risk or high risk for metastasis. Next. Let's first talk about the chromosomal analysis test. This is a karyotype, which is basically a picture of chromosomes. So what we've learned about a lot of different cancers is that when we see changes in gross chromosome structure, which is what you're looking at here, it often tells us about the cancer. Next. What we first looked at in ocular melanoma is that we noticed that the changes in chromosome 3 seem to correlate with patients who are developing metastatic disease. Specifically, when we saw, you see 2 copies of chromosome 3, when we saw loss of 1 copy of chromosome 3 called monosomy, it seemed to correlate with patients more likely to develop metastatic disease. The more we did research, the more we came to understand what was going on the chromosome level. Next. We noticed that there were changes also in chromosomes 6 and 8. The assay that's done here at the University of Pennsylvania reports out the results for chromosomes 3, 6, and 8. And right now, it is unsure what the changes on chromosome 6. They don't seem to increase or decrease the risk for metastasis significantly. The 2 that we look at as being the most significant risk factors are monosomy for chromosome 3 and amplification or duplication of genetic material on chromosome 8. I just want to show too, just so for terminology's sake, if you can see in each chromosome there's kind of a pinch in the middle of each chromosome. That's an area of genetic area that's really not, it doesn't make any genes. Above the pinched area is called the P region, and below the pinched area is called the Q region, and that I'll bring up later. Next slide, please. When we followed the clinical outcome in patients, we could establish survival curves, and that was giving us a determination of a correlation between the chromosome changes and the risk for developing metastasis. So what you're looking at here is one of those survival curves, and what it's determining is you're looking at the proportion of patients who have metastasis-free survival. So they're living and they do not have metastasis. And the blue line is disomy. So those are patients that were found to have chromosome 3 disomy, and we compared it to what is the green line of patients that had monosomy for chromosome 3. And what you'll notice next is that monosomy for chromosome 3 is significantly associated with future risk of metastasis. If you look at the interval months out from the initial diagnosis, you'll see that that green line is dropping pretty significantly and pretty quickly compared to what's going on to the blue line. However, the blue line is still showing some patients that are having metastasis, and what we saw is that the patients that were developing metastasis with disomy, that number was higher than what we expected. Next. And so we realized that the prognosis based on chromosome 3 status alone was leading to a misclassification. Next. So we looked for other frequent chromosome changes, and this is where we started to see changes in chromosome 8 as being frequent in patients that were developing metastatic disease. Next. So in patients that have normal chromosomes, so they maintain 2 copies, disomy for chromosomes 3, 6, and 8, specifically 3 and 8. If we look at about 5 years out. Most data looks at about 5 years out from the initial diagnosis. We see that the line essentially stays pretty close to straight across, a low risk for developing metastatic disease. If we see changes in chromosome 3 or changes in chromosome 8, so monosomy 3 or amplification chromosome 8, that's the intermediate. So there's an increased risk, but it's a moderate risk. And you can see that the two lines there in the middle are showing a rapid increase in developing metastasis. And then the lowest line, next, is monosomy for chromosome 3 and amplification of chromosome 8. So we see both changes in the tumor, the ocular tumor, and those patients are predicted to have the most significant risk for developing metastasis. Next slide, please. The next set of slides is not to make you an expert in biotechnology, so bear with me here as I go through some of the technology and show you. And I will answer any questions at the end of the webinar for anything that's confusing. This is an example of the chromosomal analysis that we do. If you look at the top where you see the numbers 0, 2, and 4, those are very small sections. All those little dots are areas of genetic material that we're analyzing on chromosome 3. And when the line in the middle is along the 2, that signifies to us that there are 2 copies of chromosome 3. So this is an example where it has maintained disomy. Next slide, please. When you compare this to a result, you'll see that at the top, that blue area has dropped below the number 2, so it's kind of between 0 and 2. It indicates that there's only 1 copy of chromosome 3, which is monosomy. And then that solid blue line in the middle indicates that at every point of genetic analysis that we've done, there's a deletion there, again confirming that on chromosome 3 in this sample, there is monosomy or loss of genetic material. Next slide, please. Now we're looking at chromosome 8. So again, too, all those little dots on the top are looking at very specific areas of genetic material. And what you can see is that the P region, remember we talked about the P and the Q region. So in this example, the P region has the line across there at number 2. And then beyond the centromere, the middle region where there's no genetic material expressed, you see that line shift up to about to 3. In this case, we're seeing 3 copies of chromosome 8q, and this is the amplified region that is significant for genetic analysis or predicting the risk for metastasis when we do the chromosome analysis. So this is how we do the chromosome analysis. This is a very clear picture of what is amplified and what is deleted, and that's what helps us call the result when we report it to a patient. Okay, let's move on to next slide, please. This is showing you a result that would happen with a gene expression profile. So specifically, it's been determined there is a pattern of genes, copy numbers of genes that are different between tumors that are low-risk biology or less aggressive biology versus class 2, which is the aggressive biology or high risk for metastasis. And this is kind of the same thing. You're looking at small areas of genetic material between class 1 and class 2, and what you can see is that there's a shift in the blue regions and the red regions between the class 1 and the class 2 tumors. So blue is showing you that there's a decrease in the copy number of those genes. Red is showing you that there's an increase in the copy number of those genes. And then gray would be kind of intermediate, that it's not really high or low compared to a normal set of genes that we use as a control. What I wanted to point out on the right-hand side is there's 12 genes there that are listed. They're ranked in terms of their effectiveness at predicting the metastasis risk. And then the chromosome location is also listed for each of those genes. Next, please. And next. What you'll see is the ones that I've highlighted in this gene expression profile. There are 4 genes on chromosome 3, and all of them are in the blue region, indicating that in the gene expression profile we see fewer copy numbers of those genes, just like when we see in the chromosome loss of genetic material, chromosome 3 monosomy. In these two, it does make sense that you would see less gene copy number. That doesn't always hold true, but in this case I think it is interesting that there is this nice correlation between the two assays. Next slide, please. This is also to show you the gene expression profile, that the data that developed the gene expression profile, the laboratory that developed it, also looked at these survival curves, reporting it out % free of metastasis. And so what you can see here too is there is a difference between the survival rate in terms of who's developing metastasis between class 1 and class 2. And again, the class 2 is associated with a significant increased risk of developing NETs. Subsequently, the laboratory that has developed this test has now subdivided class 1 into class 1A and class 1B. And what that seems to correlate with is the class 1A is what the chromosome analysis reports out as no increased risk. Class 1B is the changes on chromosome 3 or 8, kind of a moderate or an increased risk, and then the class 2 would be the association with the significant increased risk of developing metastasis. So this is the last slide here, but people have asked which is the better test, and the take-home message here is really that there's been no direct comparison that's been done between the two tests as they are currently performed. So that would be a nice study to do, whether there truly is a difference in how these two tests are predicting risk. But currently, with what we know about the science, we do feel confident that both tests are equally accurate at predicting a risk when a patient accepts this testing. Thank you.
Thank you very much, Susan. And there'll be time for questions and answers at the end. So please keep your questions in mind, and you'll be able to type them in once we've heard all the presentations. So thank you very much for that, Susan. And now Susan is going to give us the second talk on why do patients and physicians want a prognostic result. So Susan?
Okay, so this is near and dear to my heart because this is what I do every week is I talk to patients about the result. Once the science is completed, now we need to apply it to what does it mean to the patient. And so I'm going to go through some of the analysis that we've done in the study. So first I want to go back because I developed this talk before I developed the previous one that I did. So let's first address some questions that you might already be thinking. Next slide, please. When do we decide about testing? So if there are people listening to this webinar who have not had testing and are wondering if they can still go back and do that, the important things to remember is if the treatment for your primary tumor was done by radioactive plaque, a sample of that tumor had to be obtained prior to the plaque placement. The reason for that is that the radiation induces genetic changes that are fatal to the cell and thus killing the tumor, which is what we want. But the testing needs to be done to determine the biology of the tumor before the treatment. So if radioactive plaque was done, genetic testing would not be an option at this point. However, if enucleation or removal of the eye was done as treatment, samples can be used from frozen tumor or from paraffin-embedded tumor blocks, and that would have to be set up with either lab that you would choose to do testing to be able to get a sample of that tumor to complete the analysis. So I wanted to address that question, that for those patients who know that they've had their eye removed, we need to be able to check for availability of tumor and then decide about moving forward with testing. Next slide, please. The next couple of slides, I'm going to present some data that was determined from a study that I had done on looking at why patients accept or decline the genetic testing. I hope that some of the results might resonate with those of you who have considered genetic testing, and we certainly can talk about that at the end. Next, please. So this was a survey of patients who opted for or declined prognostic molecular testing, and there were 97 participants in the study. Next, please. All patients in the study were seen at Wills Eye Institute in Philadelphia for diagnosis and treatment. Concentrating on one center did allow us to equalize how the information was presented about the option for testing, so that when patients were making decisions, we know that they had all been presented the information equally and that we could analyze how the decisions were made. Next, please. The prognostic testing was based on changes in chromosomes 3, 6, and 8. Therefore, the choice was to opt for or decline testing. It was not to choose between chromosome analysis or gene expression analysis. And those are the two tests that are available. But at that point, the patients only had chromosomal analysis to choose. Next slide, please. And at the time of the survey, no patient had yet developed metastatic disease. The majority of the patients who answered the survey were 6 to 12 months out from their initial diagnosis, and we wanted to understand the decision process close to the time of the diagnosis, not far into the natural history of the disease. Next slide, please. This is just basically showing you, on the left is the age distribution of patients who declined the genetic testing. And on the right is a distribution of the patients, the age distribution of patients who accepted the genetic testing. The take-home message here is that the age distribution indicates that there is no significant difference between a patient's age and whether the patient declined or accepted testing. I think what's interesting is we went into this thinking that maybe patients over the age of 60 or over the age of 70 might be less inclined to order testing, and we did not see that. So age was not a factor. And then it allowed us then to say that this equal distribution in ages indicates that there are other factors that influence the decision about accepting testing. Next slide, please. So we started out by first asking both sets of patients, those who declined and those who accepted testing, what were the most stressful aspects about being diagnosed with UM? And we asked them to only pick 4. So that we didn't get answers for all of them. They're all stressful aspects, but we wanted patients to indicate which were most stressful for them. The blue bars are those patients that declined testing. The red bars are those that accepted. Next slide, please. Or next. If you look at the orange boxes here, you'll see that the 3 that came back most stressful for both sets of groups. Certainly the diagnosis itself, finding out I have cancer, is understandable. Most patients have not heard of cancer of the eye, so it is not surprising that that was a stressful aspect. The last, thinking about what the future holds for me with the risk for the cancer to metastasize, what we saw with this was interesting in that patients seem to understand between the both groups that there is a risk for the cancer to metastasize, but this concern alone for METs was not necessarily enough to prompt the decision to proceed with testing. Next slide. And then what I thought was very gratifying, and certainly something that I have observed in the clinic, is that very few patients indicated they lacked family support, and we've seen that in terms of the number of family members that accompany patients and gather information for the patient and support them. Next slide, please. So let's look first at data for patients who declined genetic testing and what influenced their decisions. Next. The cost of the test. We did see that more patients who declined testing indicated as a stressor that related to expenses in getting to specialists. And we'd like to know more about that if those are patients that had expenses related to out-of-network insurance issues, and that cost then would have been a consideration in accepting or declining the test. Next. These 2 answers, I was uncertain how the genetic information would benefit me, and I was concerned about insurance discrimination based on having genetic testing. Both of these answers and the number of patients that chose these indicated to us that we needed to start offering pre-test counseling. That had not been done at the time of this study, and we have now initiated that. So patients get pre-test counseling with a genetic counselor to go through the pros and cons of the testing. And then next. The other reasons, so patients declined for other reasons. Several patients indicated that they were concerned that the biopsy would cause metastasis, which has not been shown in the clinic. So clearly a need for education there. And then a few patients indicated that they felt that they had faith in their future was in God's hands. So those are just some examples of other reasons patients decline testing. Next slide, please. So let's move on and look at how patients said yes to genetic testing. Why patients said yes. Next. So the first one that says, I thought it was part of the process when I was diagnosed. This was interesting to me that this number, and it was gratifying that the number was low here, because this answer indicates that patients were considering the impact of getting the genetic result, and they understood that they had a choice about proceeding with testing. Next. These two, I wanted additional information about the tumor, and I wanted additional information to guide my medical decisions. This also was supporting what we were thinking that patients would want to go, why they would want to go forward with genetic testing. Next. And supporting that, some of the other reasons that patients wrote in was that they wanted a desire to plan for the future. So several people wrote that they wanted to put plans in place for the financial future for their children. Patients chose testing because they wanted to contribute to the research, and understandably too, many patients had hoped that the genetic information might provide treatment options. Next slide, please. So this is still focusing on patients who accepted the genetic testing, and the question, how do you feel the genetic information has been useful to you? Next. And we see here that the overwhelming majority of patients did feel that knowing the result, it supported their initial reasons for accepting the testing, and they felt that they had control of planning for the future. And then also some of it got caught off, sorry. I appreciate having the risk information because it decreased some of the worry in my family members, spouses, and partners. This choice was most likely applying to patients who received a result of a lowered risk for developing metastatic disease. Next, please. And what I thought was great here is the question, I regret that I pursued genetic testing for risk information. No patients indicated that they regretted their choice. Next slide, please. So due to the introduction of adjuvant therapy, we asked, what is your impression of your physician's viewpoint of the usefulness of the genetic testing information for ocular melanoma? And about 12% of patients indicated that they had not shared the genetic test result with their physician. 15% of patients indicated that their impression was that their physician wasn't sure what to do with the information. I believe that number may be reflective of patients who are monitored by primary care physicians for ordering their imaging studies, or an oncologist who isn't familiar with the disease. And then overwhelmingly, 73% said that my physician has used the genetic result in the plan for my follow-up evaluations. And so what we think is that due to the introduction of adjuvant therapy options, our lab has been seeing more physicians wanting the genetic information to help guide that discussion. Physicians do seem hesitant to put a patient with a low risk for METs and a small tumor size on a therapy where the side effects might outweigh any benefit. It's also known that the earlier that METs are discovered, the more amenable they might be to the current treatments. So many physicians are ordering imaging studies more frequently for patients in the increased risk category. Next slide, please. So most of you, many of you, some of you, we certainly received a lot of calls in the laboratory about the recent New York Times article about the expression array test. And I just wanted to address some of the points in that article. I think one of the most important things is that the title of the article and some of the quotes from Dr. Harbour gave the impression that the result from expression array is a true life versus death predictor. And it's important to understand that a risk assessment is not a yes or a no answer. It determines a % chance that metastasis will occur. Some patients in the low-risk category will develop METs, and some patients in the high-risk category will beat the odds. And the only thing that we can do with science is to improve as we continue to see those outliers, then go and look more at the genetic level and understand what makes those two groups different. Why are they unexpected from the results that they've been given? So yes, the science does need to improve, but it's not a yes-no answer at this point. It is important to use the genetic information in the context of the clinical features of the tumor. So because it's not a yes-no answer and some patients will develop metastasis, or especially in metastasis when we don't expect them to, we do need to look at the size and the location of the tumor to incorporate that in the risk assessment. And then it's important, and we've known this, and this is why we're doing these webinars, it's important to engage in an appropriate imaging protocol. We need to continue to rely on the strong family support that we've seen, and we certainly need to stay in the loop through patient advocacy groups. That's the way the word of mouth spreads on what treatments are being offered, where centers are trying those new trials. So I want to share some responses from patients from when they receive their risk assessment. Next slide, please. So these are just some quotes that patients have said to me at the time of getting their risk assessment. I feel like I can finally breathe. Now I know. Even if my time is limited, it's my time to live. It's given me a lot to think about. Can I really have peace of mind and still have cancer? Knowledge is powerful to me. I cannot put my head in the sand. This disease is so much more than just my eye. And I feel like I have a sense of control over this cancer. I have hope. Next slide, please. The final thought that I would leave you with is keep yourself educated, ask questions. However, accept that the answers can be difficult to hear, and accept that sometimes medicine still does not have the answer that you need to hear. Thank you.
Thank you so much, Susan, for those really informative presentations, and thank you so much for stepping in for Dr. Shields today. We really appreciate all the information that you have given us. And I just wanted to mention for people that we will be taking questions at the end, but that Susan kindly offered her email address and said that it was on her first slide, if for some of you who might have personal questions for Susan in particular. So now we will turn our attention to adjuvant therapies for ocular melanoma, and we're very lucky to have with us Dr. Richard Carvajal today. As I mentioned, a medical oncologist from Memorial Sloan-Kettering Cancer Center in New York. So Dr. Carvajal.
Thank you so much, Sarah, and certainly I'd love to thank the MRF for putting this together. Can you guys hear me okay? Okay, I'm going to assume that's yes. But I think
I can hear you. I think everyone else is muted, but I think it's hard to know.
Yeah, I'm just away from the office, so I'm on the iPhone and my laptop, so I just want to make sure this is working. But certainly these webinars, these educational programs, I think are really critical in allowing those of us trying to develop new therapies for ocular melanoma to better understand what you, the patients, need from us. I think we need to work together to really fight this disease. I'd also like to thank Susan for those wonderful talks. It really lays the groundwork for what I'm going to be talking about, which is really the opportunities and challenges that we have in the development of adjuvant therapies for uveal melanoma. I don't know if I can control the slides here. Why don't we go to the next slide? So to start off with, I just want to talk about what exactly is adjuvant therapy. And basically, this is treatment that's given in addition to the primary, the main, or the initial treatment. So in the case of ocular melanoma, adjuvant therapy would be treatment that we would provide after a patient undergoes enucleation or surgical resection of the melanoma, or after they go radiation therapy. And this sort of treatment can include chemotherapy or immunotherapy. It can include some of these new targeted therapies that we're studying, even hormonal therapies. And we administer this to patients in order to reduce the risk of the cancer coming back. And to do this, typically we target the patients who are at the highest risk of disease recurrence. And Susan mentioned, the reason for this would be to help, to spare patients any potential side effects of any treatments we might have to provide if, in fact, the risk of recurrence is very, very low. Now, adjuvant therapy is really standard of care for a number of cancers like colon cancer, lung cancer, breast cancer, and others. So, for instance, a patient with colon cancer who undergoes surgery, who we know is at high risk for recurrence because of some of the pathologic features of that primary tumor or the presence of lymph nodes or so forth, those patients get adjuvant chemotherapy, and we know that such therapy reduces the risk of the cancer coming back and helps prolong survival. The problem, though, is for melanoma in general and uveal melanoma specifically, we don't really have such a therapy that's been proven to reproducibly improve outcomes like that. Next slide, please. In terms of melanoma, we have really one FDA-approved drug for the use in the adjuvant setting of melanoma, and it's important to note that this is a drug that was basically approved based on trials done in melanoma, not in ocular melanoma, but that's a drug called interferon. That was approved in 1994, and there's a pegylated form, which is basically a longer-acting form that was just approved last year, but they basically work the same. This is a drug that you may or may not have heard of before because it is FDA approved for use in melanoma, and so this actually can be administered for patients with ocular melanoma. But what I want to do is just go through some of the data that got this approved and some of the limited data we have about the effects of interferon in ocular melanoma. Next slide, please. So the study that got this drug approved is something called ECOG 1684. And ECOG 1684 randomized just under 300 patients with skin melanoma after they had surgery. And so, as best the doctors knew, all the cancer was gone. And patients were randomized, like a flip of the coin, to either observation or a course of the interferon. Now, the patients who got the interferon had a year of therapy. The interferon is administered by vein Monday through Friday. So they have to go to the doctor's office Monday to Friday for 5 days in a row, and they do that for 4 weeks. And then subsequently, the patients are taught to give themselves injections of the drug in the belly, and they do that 3 times a week for the remainder of the year. Now, it's a very long course of therapy. For some people, it can be quite a difficult course of therapy because of the side effects, which include flu-like symptoms and muscle aches, joint aches, tiredness, problems with the blood counts, problems with the liver function, and so forth, to the point that about 2/3 of patients on this initial trial actually couldn't finish the year of therapy or had to have the doses reduced. Could you move forward, please? So the results of this trial were the median follow-up of about 7 years, which means that they followed all 300 patients out, and on average they followed them out for about 7 years. And they saw that at the 5-year time point, if you got the interferon, about 9% more people were alive than if you did not get the interferon. And there was an overall improvement in kind of median overall survival, or even different than the average, but the median overall survival from 2.8 to 3.8 years. And so this was significant, and this is what got the drug approved. But importantly, again, this was a study in skin melanoma, not in ocular melanoma. Next slide, please. So a follow-up study to that was something called ECOG 1690. And again, this took patients with melanoma, skin melanoma, that were resected, and this time they were randomized to one of 3 arms. Patients could either get the high-dose interferon, like they got in ECOG 1684. They could get a low-dose interferon, where patients just got the lower-dose injections in the belly 3 times a week for 2 years, and that was done in an effort to hopefully maintain efficacy while reducing the likelihood of side effects. And the third group were patients randomized to observation. Next slide, please. What they basically saw in this study was a little bit different than what they saw on the first 1684 trial. Basically, this is a curve looking at what we call relapse-free survival, and on the x-axis here is time in years. And on the y-axis here is the probability of patients doing well without the cancer coming back. And basically what you want on this curve is you want a line to go straight across the top like that. You want patients to have no cancer coming back, as long as you're looking. And what you see here is if you got interferon, whether it be the high-dose schedule, which is the dark solid line, the low-dose schedule, which is kind of this dotted line, which really parallels the dark line, you did better than if you got observation, which is this line here. This was what we call statistically significant only for the high-dose arm, though. So it seemed that there was a trend towards improvements for the low-dose interferon, but it definitely made a difference for the high-dose interferon folks. Next slide, please. What was different, though, is if you look at the survival curves, here you can see that basically the three lines completely overlap. And so unlike in ECOG 1684, where it seemed that patients who got the interferon did better, they lived longer, this trial didn't show that. Next slide, please. Furthermore, if you go back to that original study, 1684, and you see how patients, and you follow them longer term, and in this particular case, the median follow-up was 10 years, you can see that although there's still a trend towards an improvement for interferon, this, again, did not reach statistical significance. And next slide, please. And then if we combine the data from 1684 and 1690, although there's still an improvement in terms of relapse-free survival, that is, the likelihood of the cancer coming back is lower if you get the interferon, there's no impact on overall survival. And so interferon has become somewhat of a controversial topic for those of us treating skin melanoma, in that it does have some biologic activity. It can delay the time of cancer recurrence, but it doesn't seem to impact overall survival. And so that leaves us with having to kind of weigh the risks of the toxicities and the side effects of treatment with the benefits that we do see in relapse-free survival. And the question is that benefit with no change in overall survival with side effects? And so a lot of us, feel that perhaps that's not the case. Can you go to the next slide, please? So what's the experience of this drug in uveal melanoma? We don't have a whole lot. The largest study was a non-randomized trial, which looked at 121 patients with high-risk ocular melanoma, 118 of whom had proton beam radiation therapy, and 3 of whom had surgery. And they defined high risk as including patients who were 65 years or older, patients who had a tumor diameter of 15 millimeters or greater, patients whose tumors involved the ciliary body, part of the eye, or patients who had what we call extrascleral extension, or extension of the tumor outside the white part of the eye. And these patients had 2 years of kind of that low-dose interferon schedule, just injections 3 times a week in the belly. And what they did was, because we need to compare that to something else, what they did was they looked at historical controls from the same institution. And they tried to match them with these 121 patients as best as they could. Next slide, please. And so what this shows you here is, if you look at some of the key factors like age, you can see that in the interferon group, the median age was 63 years, and in the historical control group was 64 years, so there's no significant change there. And similarly, if you look at tumor diameter, it was fairly similar. If you look at the proportion of nails on the study, that was also similar, as well as the percentage whose tumors had extrascleral extension. What they did see here, though, was an increased percentage of patients with ciliary body involvement in the interferon arm, and that would suggest that this kind of patient population was perhaps a higher risk patient population than the historical control group. Next slide. Okay, so what are the results? What does this actually do? Well, this curve is a little bit different than some of the other curves that we saw. Again, on the x-axis here is time, and on the y-axis is the proportion of patients who actually passed away. And so in this case, you want the line to be straight here. You want no one to have passed away. And what you do see is that patients who got the interferon actually seem to do worse than the patients who did not. And so, what do we take away from this? Again, this is not the optimal study. It's really the question of whether this works or not. You'd ultimately want to use a randomized trial where half of the patients get interferon, half of the patients don't. You'd probably want to do the full dose interferon, which they didn't do here. But nevertheless, this is the data that we have, and the data suggests that interferon does not help. And so where does that leave us? For patients that I see with high-risk ocular melanoma, we don't even talk about it. I'll mention interferon, but say it really does not apply to this setting. Next slide, please. So although we haven't yet identified an effective adjuvant therapy, there are a lot of us who are working very hard to actually find something that can help here. And there are a lot of opportunities for the successful development of such a therapy now. And some of those are listed here. One, we have the increasing understanding of the biology of this disease. And some of these will, I'm sure, be the topic of a future webinar, but we're identifying key oncogenes or genetic events that are contributing to tumor growth. We've identified some key tumor suppressor genes that have been lost. We have identified other pathways that have been seem to be activated in this disease. And with the increasing number of novel drugs that kind of target these alterations, there are a number of clinical trials that are ongoing in the metastatic setting, which we can use to hopefully inform future adjuvant trials, and I'll go through some of those in just a little bit. What Susan spoke about is really critical, because one of the things that we have in the uveal melanoma field is that we do have known markers of risk, whether it be pathology, tumor size, the cytogenetics with the monosomy 3, or amplifications in age, or the gene expression profile. And this is really important because this allows us to identify the patients who are at highest risk for recurrence, and those are the patients that we want to put on the adjuvant trials. And then finally, there's very, very strong international interest in collaboration, which is very important for us because, as you all know, uveal melanoma is a rare disease, and it's very hard to do large definitive clinical trials unless we have many centers collaborating or many countries collaborating. We do have that opportunity. Next slide, please. So this I'm going to leave more as a reference than anything else, but this is the list of all of the ongoing uveal melanoma trials for patients with metastatic disease that are ongoing, and highlighted in red are just the ones that are ongoing in the United States. And a lot of these are really based on kind of our increasing understanding of the biology of the disease, and because of that increased understanding, I think the likelihood of one or more of these trials actually making a meaningful difference in terms of outcomes is greater than has been the case in the past. And what's going to happen, and what usually happens, what's happened in other cases where we've successfully developed adjuvant therapies in other cancers, is we take drugs that do work in the metastatic setting, and then we move it forward to the adjuvant setting. And presumably, should one or more of these trials be positive, these drugs may be worth studying in the adjuvant setting. Next slide, please. And as I mentioned, there is a really strong international interest in this disease, the United States National Cancer Institute has collaborated with a group in Europe and groups in the United Kingdom to develop this International Rare Cancer Initiative, which is really an international effort to enhance collaboration in the conduct of clinical trials for rare cancers. And thus far, there are 9 targeted cancers, one of which is uveal melanoma. And so this gives us a very good platform to use to really rapidly and efficiently enroll patients onto adjuvant clinical trials and answer the questions that we need to answer. Next slide, please. And what are the challenges? There are a lot of challenges, some of which are unique to uveal melanoma, such as one, this is a rare disease, and it is hard to enroll sufficient numbers of patients onto any of our trials to really meaningfully answer the question of does the treatment work or not. 2, what treatment should be tested? I think we're all in agreement that we need to find an effective adjuvant therapy, but the question is, which treatment should we test? What's our lead candidate? 3, which patients should be enrolled? I think with our improved prognostication strategies, with cytogenetics and gene expression profiling, I think that's a little bit clearer, and that's a strength of that's actually a major opportunity for us at this point. For what defines a positive study, ideally we want to improve survival. We want people to live longer. That's the goal of any of our trials. But to conduct a trial like that with that endpoint takes a long time. And so the question is, can we use a surrogate marker for survival, which will allow us to answer the question a little bit quicker? And then finally, how many patients do we actually need to prove that a treatment is effective? Next slide, please. This is just kind of a sample study design that I put together just to kind of illustrate the number of patients that we actually really might need. And I think ideally adjuvant trial would be a randomized trial where patients at high risk for disease recurrence would be randomized in experimental treatment or a placebo. And I'm sure there are going to be a lot of questions about the need for a placebo and the ethics of that we can talk about during the question session. But this is really the only way to definitively answer, is the experimental treatment better than just watching patients closely, which is right now the standard of care. And if we assume that we're going to look for an improvement in the primary endpoint of how long people live or whatever by 50%, and if we, I'm not going to go into the biostats, but if we use, I guess, fairly standard biostatistical assumptions, we need 142 patients to complete that trial. So it's fairly big for patients with a rare cancer such as this. I think I'm running out of time. If we just go to the next slide. So what I've listed here are the ongoing trials in the adjuvant setting for ocular melanoma. And as you see here, in the Netherlands, there's a vaccine trial ongoing. Cleveland Clinic is doing a trial where patients get not just interferon, but they add on chemotherapy to see if that can improve outcomes. San Diego is combining targeted therapy with a drug called sunitinib with hormonal therapy and chemotherapy. And then there's a trial of a drug called ipilimumab, which should be open for enrollment at MD Anderson in the near future. Sarah, do you think, I think I've got 3 or 4 more slides left. Do you think I should continue on?
Can you summarize them
I think
quickly, and then we can try and take questions? And maybe in the meantime, listeners who have questions could go ahead and start typing them in as you're wrapping up. Maybe that's the way to do it. So why don't people who have questions go ahead and you can type them into your chat box, and we'll try and take a few minutes after Dr. Carvajal to answer some questions. So go ahead.
Thanks, Sarah. Why don't we go to the next slide? I think let's actually skip through this one. We'll have to press a few buttons, actually. And this is basically just talking about ipilimumab. And the reason for this is, and just one more slide, please. The reason why I wanted to talk about ipilimumab specifically is because this is a drug that's been proven to meaningfully impact the way people with skin melanoma do in the metastatic setting. This is actually the first drug to ever show that it helps people with metastatic skin melanoma live longer. And next slide, please. And so now the question is, does ipilimumab work in metastatic setting in uveal melanoma, and is this something that we can move forward to the adjuvant setting of this disease? We did actually report a small series, but it's actually the largest presented series now of ipilimumab in uveal melanoma. And these are the patients who we treated at Memorial. And the median age in this series was 61 years. There were 11 males and 9 females. These patients, as is common for ocular melanoma, a lot of them had liver involvement. A few of them actually had brain involvement as well. Next slide. And could you click one more, please? And really, the bottom line is this. If you look at patients 12 weeks after starting therapy, about 40% of the patients were doing pretty well. In that some of the patients had tumor shrinkage, a lot of the patients had disease stability. And by 24 weeks, that number did drop a bit to 25%. But if we look at how patients with skin melanoma did, it's very, very similar to this. So based on this data, it seems that ipilimumab works perhaps as well in uveal melanoma as it does in cutaneous melanoma. And again, in cutaneous melanoma, despite these these percentages, which are not where we want it to be, it did meaningfully impact survival. It helped people live longer. And so I think this is still an important drug for uveal melanoma, and in fact there are multiple trials looking at this drug in uveal melanoma, which are going to be on beginning in the near future. Next slide. So MD Anderson will be looking at this drug in the adjuvant setting, and they are enrolling patients with high-risk diseases defined as having a class 2 gene expressing signature that Susan spoke about previously. They can have monosomy 3, where they can have a tumor with a thickness greater than 8 millimeters. And here patients get the ipilimumab drug for a month. And here it's not a randomized trial. They're going to put on 83 patients. And they're going to try to compare this with historical controls to see if this meaningfully impacts how people do in a beneficial way. Study should open up in the near future. Next slide, please. So this is my last slide. In summary, one, there's a clear need for the identification of an adjuvant treatment for uveal melanoma that can effectively reduce the risk of disease recurrence. 2, emerging insights into the biology of uveal melanoma that led to the development of a series of clinical trials in the metastatic setting, which holds promise for positive clinical impact on this disease. And importantly, lessons learned from these and other clinical trials will need to be applied to the development of adjuvant trials. Next, a definitive adjuvant clinical trial will require a randomized design and will likely require international collaboration for rapid accrual. And the last point is that, again, patient participation, we need you guys to help us do these trials. Because without your help, we're never going to be able to answer the questions of do some of these new therapies work. So I'll leave it at that, and thanks for the opportunity to speak.
Thank you so much, Dr. Carvajal. Really, really helpful information. Really appreciate your time. So I'm noticing the time and really want to be respectful of everyone's time here. So maybe we'll take 1 or 2 questions. And then if you have additional questions, you can feel free to contact me by email, and perhaps I can forward the questions on and get the answers back to you. So I think we have maybe 1 question. Scott, do you want to ask the question?
I see there are a number of questions here. First question is, will we be posting these slides? Yes, we will be posting them.
The slides will be posting on the CureOM website, which is www.cureom.org. So they will be online soon.
And I think the easiest way to answer a couple questions, if somebody would just indicate they'd like to answer a question, we can open their mic briefly and ask the question. They can just raise their hand. Okay, I'm going to open up David Stewart's mic and raise his hand.
Hello. You know, I have not been referred to any adjuvant therapies, and I am high risk. And at the moment, my doctors are really just sitting, which I appear to be healthy, but you know, with the risk that I have, and I'm young at the moment and want to remain alive as much as I can, I still think I'd benefit from treatment and study, and I'm just wondering if that's true and really how to go about it and more get my doctors on board.
I guess the question is, you know, if you're a patient with high-risk disease, what should be done? And I think all of us, you know, when I see patients in your setting, you know, our gut reaction is, you know, wow, we really want to try to do something to reduce the risk of this coming back. But the unfortunate truth right now is that there is no therapy that we know of that does that. And so, although we could give you chemotherapy or interferon or various therapies, there is no data that says that by doing that we're actually doing you any good. And we're clearly putting you at risk for side effects from those therapies. So for patients in your setting, what we really need are more clinical trials, testing therapies that are showing promise either in the lab or in small prior pilot studies. So that's why I put up one of those slides there where I did list there will be 3 ongoing adjuvant trials, both once the MD Anderson trial opens up, and all of it. My hope is that we're working on a number of other adjuvant concepts, which very well may be open in the next 6 months or so. And so I hope to see more opportunities for you soon.
Well, my concern is that I'm, I may be feeling fine at the moment, but then I do my scans and so forth. But what if it starts to crack, and I just had a scan and it showed nothing, and then a month later, I'm as holistic as my original tumor. And by then it might be too late. I'm just concerned about the, sitting here and not having anything to do isn't protecting what might happen in the future.
That's right. So, what we need to do is just more rapidly come up with therapies that we think are worth testing in the adjuvant setting. I completely agree with you. We need something.
Thank you, Dr. Carvajal. Maybe we'll have time for 1 or 2 more questions. Scott?
Stephanie Vander Worker, I'm opening your line.
Hi, my question is kind of similar to the last one, but just phrased a little bit differently. You indicated that with these studies you're utilizing the risk pools that are high risk, bigger tumors, and then if there's the genetic test, people that are in the higher risk pool from that. Is there any type of work being done with people that are in the low risk pool, or people that may not have had the opportunity to get the genetic test, meaning they've already been treated? Is there anything being done for that group?
So that's a good question. So one point of your question is do we need to develop an effective therapy for the low-risk patient population? And the answer is, I think maybe, because with any adjuvant therapy, again, you have to weigh the risks and the benefits of the treatment, and that's going to differ depending on the patient's risk for recurrence. So a patient is at very high risk of recurrence, we maybe will be willing to take a treatment with a higher side effect profile than if that was a patient with a low risk setting. Now the trials that are ongoing and the trials that are going to be developed, I suspect will all be for the high risk patient population initially. And the reason for that is because we can answer the question of whether that treatment works quicker in the high risk population. Because unfortunately, more patients in that population are going to have the cancer come back than in the low-risk population. And we need those events to occur on the trial. And this sounds terrible, I know, but we need those events to occur on the trial to actually help us differentiate if the treatment's doing anything at all.
Okay, thank you. I think we'll take one last quick question, and then we'll have to follow up on email or on our online forum. Scott, is there one more question?
Yes, Paul Rosenberg.
Yes, hi. Can you hear me?
Mm-hmm.
Go ahead.
Yes.
If you can't change the genes on the chromosomes that are giving vent to the expression of the cancer, then what are you trying to do with the therapies?
Yes, could you repeat that question one more time?
You can't. Hello? Can you hear me?
Yes.
Go ahead.
Yeah, if you can't change the genes, or they've mutated or whatever they've done, the genes on the chromosomes that are giving the expression to the disease, then what is really the therapy? What's the point of the therapy?
So that's a very good question. It's a very complicated question, and I think it depends on exactly which kind of genetic event we're talking about. But what we're able to do in some cases is look at the effects of that genetic change. What are the downstream effects? Are certain pathways turned on when they shouldn't be? Are certain pathways turned off when they should be? And in those cases, in some of those cases, we have various drugs, agents, therapies that can affect those downstream pathways and in some way perhaps normalize the way the cell is supposed to function. In other cases, one of the trials that we're doing now is looking at a drug called verinostat, or SAHA, which is a drug that can actually broadly change the gene expression of cells, of tumors. And so in some cases, we can actually change the gene expression to a more favorable state. And I can keep, so that's a very complicated question that you asked. I don't know if, and I can talk at length about that, but hopefully that was a sufficient answer for now.
Yeah, if I can just interject, so the two tests that are on the market now, neither of them is identifying specific genes that are known to be targets in the therapies. So there is more knowledge that needs to be gained as we look at these tumors and get a better idea of what other genes are expressed that could be targets for therapy. But currently the result that you're getting is still a risk assessment, not necessarily saying which adjuvant therapy is going to be the most effective.
Thank you very much. Thank you for all the participants and for those really good questions. I'm sorry that we've run over and that we don't have time for more questions right now. I want to thank both of our speakers so much, and thank Susan in particular for pulling together two presentations today since Dr. Shields could not be with us. And if you have additional questions that have not been answered, please feel free to come to the CureOM online forum, and we can discuss them there, or feel free to email us at cureom@melanoma.org, and we can try and get the questions to both Susan and Dr. Carvajal and get back to you with answers. So thank you for joining the first Melanoma Research Foundation CureOM webinar. We really appreciate your participation. The second webinar is planned for November 20th, 2012, and it's on our website, and you'll be getting reminders on Facebook and other places as well. It's from 5:30 to 6:30 Eastern Standard Time. It is on systemic therapies for ocular melanoma, and speakers will be Dr. Jeffrey Weber and Dr. Keith Flaherty. Again, for other upcoming events, you can follow us on our webpage, on Facebook, Twitter. Always feel free to email me or any of us with questions. We really want to have open communication with the ocular melanoma community and be a community as we approach this together with physicians as well and other healthcare providers. So we really thank our panelists today and all the participants, and we look forward to being in touch with all of you soon. Thank you and take care.